Vinir, shall we start? Vinir? Shall we start?
Sir, we can start. We are on live.
Okay. So, good evening, respected speaker, Dr. Mridul M. Pandit Rao, who is speaking on fluids in anesthesia practice. And Dr. Shadi Sudan, who is presenting the journal presentation on perioperative fluid management for major surgery from Government Medical College, Trichy. This is the second PG update organized by ISA Kerala State Chapter. On behalf of the State Chapter, I welcome you all to this meeting. Now we have moderators, Dr. Rajesh and Dr. Vijesh. I request Dr. Rajesh to introduce today's topic and today's speaker. Over to Dr. Rajesh.
Sir, before that, I want to mention 2-3 things. The participants, they can put the queries in the chat box, and on the end of the session, we will discuss the questions. And after that, after discussing the questions, we will allow you to speak. While you are putting your questions, you should mention your name and the name of the college, so that we can identify that who is asking the questions. Then another thing, we have started WhatsApp group to communicate about academic activities of ISA Kerala State Chapter. So PGs, those who are interested, they can forward the mobile number to me so that I can include in the WhatsApp groups. Even non-ISA members also I am including now. So please, for those interested PGs, those who are interested, please forward the numbers to me. And for next week, the topic will be physics for anesthesiologists. And Dr. Baburaj from Trivandrum Medical College consented to take the topic. So welcome all you for next Saturday's topic also. And thank you. And over to Dr. Rajesh and Dr. Vijesh. Dr. Rajesh, please introduce our today's speaker, Dr. Mridul M. Pandit Rao. He is my teacher. Please, sir, please.
Good evening, my dear friends. It's a pleasure to introduce our today's esteemed faculty, Dr. Mridul M. Pandit Rao. Presently, he is working as a professor and head of the Department of Anesthesia at SIADH Institute of Medical Sciences and Research Center, Punjab. In a span of more than 33 years, mostly in an academic environment, he has worked many prestigious institutions in India and abroad, including PGI, where he graduated and met his spouse, Dr. Minus M. Pandit Rao. Then he has worked in Mahatma Gandhi Institute, Sevagram, Wardha, D.V. Patel Medical College, and Princess Margaret Hospital, Bahamas, University Hospital, West Indies, Kingston, Jamaica. He's also is in the roster as a consultant in United Nations Volunteer and Commonwealth Secretariat. He's in the panel of reviewers in Indian Journal of Anesthesia, Journal of Anesthesia and Clinical Pharmacology, and Anesthesia Essays and Researches, which is an official publication of Saudi Forum of Anesthesiologists. And he's the editor-in-chief of textbook on comprehensive pain management and authored two textbook chapters and chapters in Principles of Anesthesia, and has more than 64 publications, mostly in indexed and international journals. His field of interest includes pediatric anesthesia, neuroanesthesia, pain, critical care, and endoscopic airway management. Sir, it's really a pleasure, and we are very fortunate to have you here. Professor Mridul Pandit Rao, he was down with fever for the last couple of days. In spite of that, he agreed to take the sessions, and we pray for your good health and smooth recovery, sir. And it reflects his commitment towards his students and towards the profession. He's in 100% teacher can only commit can have such commitments. Welcome you to this session, sir. Thank you.
Thank you, sir.
Right.
Vinil, shall I start or will we are any?
No. We are waiting for you, sir. We are waiting
Oh,
for
you
you.
are waiting for me. I'm so sorry.
Yeah.
I thought, okay. So, respected Dr. Nazar sir, Binil, Dr. Binil, Rajesh, Vijesh, I thank you very much for this opportunity, for inviting me and giving me, I'm going to discuss this important issue with the students regarding the fluids and management. It is my pleasure to be here. I will start sharing my screen now.
Yes, sir.
So after that introduction, I'll just make one request to all of you. Because of this COVID problem, sometimes I do get little dyspnea. So kindly excuse me if I have to stop in between for a minute or two. So let us go ahead with the today's topic, and it is fluids in the anesthesia practice. So, ladies and gentlemen, water is life. Life on earth started in water. Journey of human life starts in water. But at the same time, water is almost also the dramatic paradox, because too less or too much is incompatible with life. In fact, it would not be an exaggeration to say that the whole life is geared up around maintaining the equilibrium of preventing too less or too much. The whole life, the living thing spends in maintaining the fluid balance and the pH balance. Quantitatively, it is the most important body constituent. In males, it is around 60% of the total body weight, while in females, it is around the 50%. And the lesser percentage in females is because of the larger fat content. The water is found in each and every tissue of the body, including bones and cartilages. We can broadly classify the body compartments into following compartments. Total body mass can be divided into total body water and the solid tissues. The total body water, or TBW, is further divided into an extracellular compartment, or ECF, and intracellular fluid, or ICF. ECF is further divided into intravascular fluid and interstitial fluid. So this is the overall broad distribution of the total body mass. Out of that, now, if we come to the percentage distribution of various body compartments, when we take 40% is the total tissues and the remaining 60% is the fluid or the water, we just mentioned that. Out of that, 40% is the intracellular compartment and only about 20% remains in the extracellular compartment, which is further divided into 10%, 15% interstitial and only 5% intravascular compartment. So now comes some certain definitions we need to discuss. Total body water. What is total body water? the sum of intracellular water and extracellular water or volume. The latter consists of, as already mentioned, interstitial or tissue compartment and the tissue fluid, and the intravascular fluid or plasma. And that comes to around 60% of the body weight. While extracellular fluid is the water content found outside the body cells, and it constitutes major two compartments, intravascular and interstitial. Also contains transcellular fluid. Now, this is a slight variation than what we just discussed. We need to consider these also, although they are such a minor in terms of percentage that they don't matter when we talk about the fluids. But we must mention them also. The fluids of the eye and the secretory glands, saliva, then gastrointestinal tract, sweat glands, in the cavities and the channels of brain and the spinal cord, that is CSF, lymph, in the body cavities lined by the serous membrane, moisture exuding membrane, and in muscular and other body tissues. Ingested water or water produced by the body metabolic processes, that is called as metabolic water. Now coming to the major part of the fluid, that is the intracellular fluid. And that is the fluid within cell membrane of the tissue cells throughout most of the body, containing dissolved solutes that are essential to essential to electrolytic balance and the healthy metabolism. It is also called as intracellular volume water, and it constitutes about 40% of the body weight. Now here we can generalize a rule of 1:3 or 1/3. Out of all the compartments in TBW, we can manipulate only the extracellular compartment, and that also more specifically only the intravascular compartment. We do not have any control over rest of the two compartments. So the quantity of ECF is generally 1/3 of the total body water, and quantity of the intravascular compartment is 1/3 of the extracellular fluid. Coming to the intravascular volume, and of course it is nothing but blood. So the blood volume is the volume of blood which includes both red blood cells and plasma in the circulatory system of any individual. Effective circulatory volume, that is the proportion of intravascular volume and thus of extracellular fluid that is effectively perfusing the tissue cells. It is in direct proportion to the extracellular fluid and the solute content dissolved in it, especially the sodium salts. Why are we discussing solutes? Because solutes are the ones which hold the water inside the extracellular compartment, especially intravascular compartment. So we need to know what exactly is a solute. We talk about solute and osmolality, tonicity. And very briefly, we are going to discuss all these topics here today. Solute is a substance dissolved in another substance or water, both of inorganic as well as organic origin. Solutes in extracellular fluid, by and large of inorganic type, is, for example, sodium, chloride, bicarbonate, etc. While solutes in intracellular fluid, that is mixture of both potassium, organic phosphate esters, that like ATP, creatine phosphate, dextrose, etc. are there. Coming to a very important number, we must understand this concept. What is a mole? What is molality? What is molarity? And what is Avogadro's number? Although we may not be using it in day-to-day life, but to get the fundamental concepts clearer, it is advisable to go through this discussion also. Avogadro's number is the number of molecules in 1 mole of a substance. And that is example is 6.022 multiplied by 10⁻23. Now, what is a mole? A mole is the amount of substance that contains the number of molecules equal to Avogadro's number. So basically, I have just told you same thing what I have mentioned above. So I will expand on that. The mass in gram of 1 mole of a substance is the same as the number of atomic mass units in 1 molecule of that substance, and that is what is called as the mole. For example, the molecular weight of a substance which is expressed as grams. Suppose if we have a substance which what its molecular weight is, let us say 37.5, as is the molecular weight of sodium chloride. If we express it in grams, then it will be called as the mole. The mole is the base unit or in the SI system for the amount of a substance. Now, what is molality? Molality is of a solution. It is not of a substance. Molality is a parameter of a solution. It is a number of moles of a solute per kilogram of solvent. So we have to understand that whatever the moles are available in the solute of the solute in a solution with per kilogram of solvent is called molality, while molarity is the solution in the is a number of moles of a solute per liter of the solution. There in molality we used per kilogram of solvent, and in molarity we are taking the entire product, that is the solution. Now coming to another very confusing term, what is called as osmole, and that is the amount of substance. Kindly excuse me, sorry. Okay. Now, what is the osmole? That is the amount of substance that yields in ideal solution, and that is the number of particles which are equivalent to the Avogadro's number. That would depress the freezing point of the solvent by 1.86 kelvins, and that is what is called as osmole. While osmolality and osmolarity, again same thing what we just discussed, molarity and molarity. Now we are expressing this in terms of osmolality and osmolarity. So osmolality is the measure of a number of solute particles present in the solution and is independent of the size or weight of the particles, expressed as milliosmoles per kilogram of water. Here we are using water as a kilogram, not as a liter. When we use liter, that becomes osmolarity. So osmolarity is a number of osmoles of solute per liter of solution, that is m osmoles per liter. I know this is a bit confusing, but we will try to cover as much we can. The value measured in the laboratory is usually referred as osmolality, and the value calculated from the solute concentrations is reported by the laboratory as the osmolarity. So the difference is the value measured in the laboratory is usually referred to as a osmolality, but while calculated from the solute concentration, they report it as a osmolarity. And the osmolar gap is the difference between these two values. So this covers mainly the osmolality, osmolarity, and other issues related. Now coming to the another very important and very confusing term, what is called as tonicity. And what is tonicity? Tonicity is basically nothing but the effective osmolality. So if we go back and we discuss, so osmolality, as we discussed, is the solution of a solution is a number of osmoles of solute per kilogram of solvent, and that is what here tonicity says. It is an effective osmolality and is equal to the sum of the concentrations of the solutes which have capacity to exert an osmotic force across the membrane. So this is important thing to understand. Whenever we talk about tonicity, we are trying to talk about the effective force, osmotic force, which has been generated by a solute across the membrane inside which this solute is situated. So osmolality is a property of a particular solution and is independent of any membrane, but tonicity is a property of a particular solution in reference to a particular membrane. So that is a slight difference between osmolality and tonicity. Osmolality will be without any encumbrance of in which membrane this solution is present, while tonicity is always in reference to a particular membrane. So ideally, when we talk about the tonicity, isotonicity or hypotonicity or hypertonicity of a fluid in relation with plasma, we are not doing correct statement. It is slightly, in principle, it is wrong. It is strictly wrong to say that this fluid or that fluid is isotonic with plasma. But what should be said is that the particular fluid is isotonic with plasma in reference to the cell membrane. By convention, because it is too cumbersome to say cell membrane, and anyway we are talking about the whole thing inside the body and in relation with the cells only. So this specification is not needed in practice, as it is understood that there is only one membrane, and for a reference, that is only cell membrane. So tonicity is in relation with plasma and reference with the cell membrane. So now what is the difference between tonicity and osmolality? Tonicity refers to what the cell does in a certain environment. I will explain this. If the environment is hypertonic, then the cell will shrink due to water leaving the cell. Now you will understand why tonicity should be mentioned in reference with a cell membrane, because the hypertonicity or hypotonicity is indirectly in reference with the cell membrane. If the cells are put in a hypertonic solution, or other way around, if a hypertonic solution is infused in the intravascular compartment, as it reaches the various cells and starts perfusing it, the cells will start shrinking. Classical example is when we use osmotic diuretics like mannitol, or even hypertonic saline like 3%, which causes the shrinking of the cell and reduction of the intracellular fluid and the edema. On the opposite side, hypotonic means water enters the cell. Sorry, excuse me. Hypotonic means water enters the cells to make it more expand, and many times it can actually cause explosion and the tissue damage. While osmolality refers to the relative concentration of two solutions, hyperosmotic means the concentration of solutes outside the cell is greater than the concentration inside the cell. Now you will understand the basic difference between osmolality and tonicity. Tonicity is always in connection with the cell membrane, which is separating the fluid from the intracellular compartment, while osmolality is only relative concentration of two solutions without any encumbrance of the cell membrane. If a hyperosmolar or hypertonic solution was administered to a patient, this would tend to cause water to move out of cell. So hypertonicity I just discussed, it is directly in relation with the cell. Now when we talk about hyperosmolality, although it is of no consequence in terms of the cell, the physical forces will cause the fluid to shift across the membrane. So in effect, when we talk about hyperosmolarity or hypertonicity, we are talking almost the same. electrolytes. We talk about electrolytes, we say get the urea electrolytes, creatinine done, and so on and so forth. But we need to also discuss what is meant by electrolyte. And it is a substance that ionizes when dissolved in a suitable ionizing solvent such as water. You see, we have to understand that water may be an absolutely neutral solvent with a pH of 7.0, but it has a beautiful property of ionizing into H plus OH minus. And because of this, the substance, whatever substances which are dissolved in it, it tries to ionize them. And this includes most of the soluble salts, acids, and bases. Some gases, such as hydrogen chloride, under certain conditions of high temperature and low pressure, also can function as electrolytes. And when we talk about electrolytes, also we have to discuss, because it gets ionized into two different type of ions. One is called cations. Cations are basically positively charged, and they are, as we know, sodium, potassium, calcium, magnesium, while anions are anions are negatively charged because of chloride. That, for example, chloride, hydrogen bicarbonate, hydroxide, hypophosphate, and sulfate. Just quickly mentioning the various concentrations of the main electrolytes per compartment, we have to understand very categorically, ECF is the most important, sodium is the most important cation of extracellular fluid, and that is 135 to 145 milliequivalents per liter. And intracellularly, it is hardly any 8 to 10 milliequivalents per liter. While potassium is the most important cation of the intracellular fluid, and this is the basis of the production of action potential and the generation of the activity in the electrically stimulation tissues like brain, motor neuron, our neuromuscular junction, myocardia, the pacemaker, etc. While calcium also is a main cation of extracellular fluid, and intracellularly it is hardly any presence there. While magnesium is another positive cation or cation of intracellular fluid. And when we come to the anions, the chloride is the main anion of extracellular fluid, while phosphate and sulfate are the anions of intracellular fluid. Bicarbonate, with its whatever importance in terms of the pH and the buffering and the acid-base equilibrium, is the major important player in the extracellular fluid, intravascular fluid. It is everything based on regarding pH is mainly channeled through the bicarbonates. Coming to plasma osmolality. Plasma or serum osmolality is a number of solutes dissolved in plasma, and their normal range is 275 to 290 milliosmoles per kilogram of plasma. Because we are talking about osmolality, we are talking in terms of kilogram. And equation for calculation of plasma osmolality is, plasma osmolality is equal to twice the number of sodium milliequivalents in terms of milliequivalents plus serum glucose divided by 18 plus BUN, that is blood urea nitrogen, divided by 2.8. Conversion factor of blood urea nitrogen is, that is blood urea milligram per DL divided by 2.14. So P osmolality comes to 2 multiplied by sodium concentration, that is twice the sodium concentration, plus serum glucose divided by 18, blood urea multiplied by 2.8 divided by 2.14, because we have tried to convert the blood urea into blood urea nitrogen here by using this equation. I'll be very brief about how the body water is regulated, because it is beyond the, there are many topics actually. These will require their own one full lecture. It would be impossible and beyond the purview of today's discussion. But I'll just mention that increase in osmolality stimulates osmoreceptors in the anterolateral hypothalamic nuclei. We have to understand that the hypothalamus is the main station for maintaining the body water, and that can lead to thirst. Neurohypothesis is immediately stimulated, and ADH, that is antidiuretic hormone, and arginine vasopressin or AVP will be released by neurohypophysis, and then there will be decreased excretion through the kidneys and increasing the reabsorption. As I mentioned, this whole thing itself is such a vast topic. One of these days, whenever it is possible, we can actually discuss this topic also. Now coming to one of the major factors which needs to be discussed and taken into consideration when we are talking about the patient management in the critically ill patients or intensive care unit patients. There is something called insensible water loss. What is meant by insensible water loss is that this every second, every minute, certain amount of water is being lost, but which is not so visible. Urine output is visible. So we know how much amount of urine output the patient has produced in first those 24 hours. But there are certain tissues and there are certain processes which require body water to be lost, and the most important tissue is the skin, 400 to 450 ml per day. Even the respiratory system, because it requires the humidification of the gases, almost again similar, 400 to 500 ml per day is lost. Almost 100 to 200 ml will be lost in the stool, in the GIT. Now mind you, sweat is not insensible loss. You have to understand a slight difference between skin loss, insensible skin loss, and the sweat. Sweating is considered a different kind of loss. It is not the regular insensible water loss which happens depending upon the ambient temperature. And when we calculate these total minimal loss around 1 liter per day. So calculation, so daily total imperative requirement in a surgical patient is absolutely required minimal urine output plus 800 to 1000 ml. So in a 60 kilogram male, we want a minimal urine output of 0.6 to 0.7 ml per kg per hour plus around 800 to 1000 ml. So it comes to around, in a 60 kilo male, around 35 to 40 ml per hour, and which will approximately come to the 1000 ml and plus 1000 ml. So generally speaking, in a surgical, post-surgical or a surgical patient, the first 24 hours, we will be requiring 2000 ml of fluid in first 24 hours. And generally you will understand that the surgical colleagues have a very peculiar tendency of making it 80 to 100 ml. They have not gone through this kind of calculation or anything. That is beyond the purview of their understanding all these concepts. They somehow have understood that by giving this magical figure of 80 to 100 ml, generally things work out well. Now coming to the most important aspect, that is a classification of IV fluids. And we need to classify them because we need to understand which fluid is to be given and what condition and what are the indications, contraindications, etc. So on one side, it is blood and blood products. We shall not be discussing this topic because again, this is beyond the purview of today's discussion. It will require its own almost 45 minutes to 1 hour of a lecture. So we come to the non-blood IV fluids and we divide them into colloids and crystalloids. Crystalloids are either glucose containing fluids, electrolyte solutions, or mixed kind of their chemical composition. While in colloids, we divide them into proteinous and non-proteinous. Non-proteinous are basically, at one point in time, there used to be fluids called dextrans, and they were divided into further lomodex, that is low molecular weight dextran, macrodex, that is macromolecular weight dextran, and rheomacrodex, that is a very large molecular weight dextran. But because of whatever, we'll discuss that, they are no longer being prescribed and used. Now coming to the starches, mainly hexaethyl starches and its further generations, that is pentastarch and tetrastarch. Now coming to proteins, mainly polygellins, that is hemaxyl, gellifusin, and of course albumin. Albumin is again generated by recombinant technology. It is not taken away from any animal or any plant, any person. It is generated from the recombinant technology. Now coming again, now we'll come to the, now once we have discussed these fluids, now we'll come to the relative tonicity. So which are the isotonic to plasma in reference with the cell membrane, and they are Ringer lactate, 1 normal saline, and D5W. For sake of saying, D5W is basically a isotonic solution, but once it is infused, once it passes through liver, first pass, the sugar is taken away preferentially by the hepatocytes, leaving the remaining fluid to be hypotonic. So you must have noticed that during our generally in intraoperative and postoperative period, unless and until there is a specific indication, anesthesiologists and intensivists do not like to use D5W. Coming to hypertonicity or hypertonic, 5% dextrose in normal saline, 5% dextrose in Ringer lactate, 5% dextrose in half normal saline, and of course the ubiquitous 3% normal saline, 3% sodium chloride. Hypotonic, half normal sodium chloride. 20% albumin has an osmotic effect 5 times its volume. We have to understand the difference between 20% and 5%. Why 20%, although given only 100 ml, is a preferred fluid as compared to 5% when we want to use it as a plasma expander, because of its osmotic effect on the fluid, on the membrane. It increases the volume, intravascular volume, by 5 times. For example, generally it comes in the bags of 100 ml. So if we give 100 ml, the plasma volume will increase by almost 400 to 500 ml. Generally, it has to be given at the rate of 1 to 2 ml per minute, and correcting fluid deficit is absolutely imperative. So we can, after giving or along with albumin, it would be advisable also to give a crystalloid to overcome if there is any deficiency which may generate by giving this 20% albumin. While 5% albumin will increase only by 100 ml. That is 0.5 to 1 ml per minute if it is given that way. So these are the important things to remember in terms of tonicity. Now coming to the crystalloids. What are crystalloids? And crystalloids are generally, they are the first line choice for fluid resuscitation in hypovolemia due to hemorrhage or hemorrhagic shock, sepsis, and even dehydration. To achieve the goals as a solution of intravenous, and in addition to that, these are 4 different also modalities where we have the crystalloids very useful. That is as a solution for intravenous medication delivery. Whenever we want to give the drugs, dilute them or give, generally normal saline is used as the vehicle or as a solvent. And even if we have to give antibiotics or drugs, we like to put them in 100 ml or 500 ml of a crystalloid and then deliver that to the patient. To deliver maintenance fluid in patients with limited or no enteral nutrition. Due to whatever reason, if there is a enteral nutrition has not been possible, then we have crystalloids as an alternative. Whenever there is a fall in blood pressure, first choice is generally crystalloids, and to increase the diuresis to avoid nephrotoxicity or a toxin-mediated end organ damage. These are the 4 additional important things to remember. What are the various crystalloids? We will go in that. Normal saline or 0.9% normal sodium chloride solution. Generally, this is a salt solution. While lactated ringer or Hartmann solution and acetate lactate, these are all, even acetate gluconate are the buffered solutions. While hypotonic saline, that is 0.05, half normal saline, is a hypotonic solution, and 3% NaCl is a hypertonic solution. 5% dextrose in water is another crystalloid, and 10% dextrose in water is another crystalloid. There are isolite P, isolite G, many of those small, for especially for pediatric age group. Generally, they come in this similar kind of discussion, whatever we have done here. So we'll go ahead with their proposed mechanism of action. How do they act? What do they do? Why do we have to consider crystalloids as the primary choice whenever we have a fluid deficit condition? A crystalloid is an aqueous solution of mineral salts and other small water-soluble molecules. And most commercially available crystalloids are isotonic to human plasma. Sorry. So they approximate concentrations of various solutes found in plasma and generally do not exert an osmotic effect in vivo. Crystalloid fluids function to expand the intravascular volume without disturbing the ion concentration or causing significant fluid shift between the intracellular, intravascular, or interstitial compartment. So I hope it is understood by everybody that because of their isotonicity with plasma, they do not interfere per se on the solutes and the other factors which may govern shift of the fluids from one compartment to other. So if we are giving isotonic crystalloid, it has a tendency to remain in the intravascular compartment rather than leaving interstitial compartment, going into interstitial or intracellular compartment, unless and until, of course, the plasma colloid oncotic pressure is so low that the pressure gradient is generated and fluid simply has to move across the membrane to enter into these fluids. So this is basically the principle or the proposed mechanism. Now coming to hypertonic solutions such as 3% saline. It contains higher concentrations of solutes than found in human serum or plasma. And as a result of this discrepancy in concentration, these fluids are osmotically active, while isotonic fluids are inert. They do not exert any osmotic force on the membrane, but these are osmotically active and therefore will cause fluid to shift. Generally, fluid will be shifted from interstitium, first intracellular and then interstitium, into the intravascular compartment. Their primary indication is of emergent replacement of serum solutes, especially in hyponatremia with neurologic symptoms. So it is to be very clearly understood that unless and until there is a very specific indication, hypertonic solutions are not to be routinely administered because they are osmotically very active. How do they act? Buffered solutions. Now coming to the buffered solutions. Buffered solutions are mainly, as I already mentioned, Hartmann's, that is lactated ringer, acetate or gluconate, etc., etc. Buffered solutions contain molecules that metabolize in vivo, that is inside the body, to bicarbonate. Most of these molecules, whichever we administer, are going to be metabolized ultimately to bicarbonate. These solutions were designed to sustain normal physiologic plasma pH. The three commonly used molecules are lactate, acetate, and gluconate, as I already mentioned. Lactate and gluconate are hepatically metabolized to bicarbonate, while acetate is predominantly metabolized peripherally by skeletal muscle. Now, how to administer? I am sure all of you know this. I just wanted, at the cost of repetition, just wanted to emphasize that in an acute setting, rapid infusion of crystalloid may be indicated, and it should be administered via a large bore peripheral line, 1 or 2, 18 gauge and above, or through central venous cannula. Advantage of central venous cannula is, of course, blood and blood products also can be given. Rarely, to overcome the deficit and to push the fluid in, the pressure apparatus to the bag of fluid also may be required. I'm sure all of you know this. In your operating theaters, you have already seen this being used. Now, how to administer? That is the maintenance fluid. In 1957, Holliday and Segar were very, very smart people. They were pioneers. And they gave us general idea. Before 1957, everything was haphazard. Nobody was absolutely sure what induction would be started. Induction means the initiation of IV fluids would be started, but how to maintain that and then what to do, how much to calculate, that was a major problem. So they did a lot of studies on dogs, and they came with the fluid requirement of a patient was related to their caloric requirement. Since this time and since that time, they gave us a general idea, and lot of modifications, lot of changes have taken place. The initial formula has been modified to provide clinicians with the guidelines for administration of maintenance crystalloid fluid, and generally what we call it is a rule of 4-to-1. That is 0 to 10 kilograms is generally 4 ml per kg per hour. Next 10 to 20 kilograms is 2 ml per kg per hour. And more than 20 kilograms, it will come to around 1 ml per kg per hour. And generally, you take this formula or you take the previous one which I mentioned. Generally, it comes to, in a 60 or a 70 kilo patient, generally it comes to that same magical figure of 80, 90, 100 ml per hour. Of course, 4-to-1 formula or rule is a boon to everybody, and one must understand it very clearly. Although we have been praising lot, crystalloids a lot, but they themselves are not without their own adverse effects, and we must understand what exactly are the adverse effects. The volume expansion with crystalloids may cause iatrogenic fluid overload, especially if we are not careful, do not monitor them, as may happen on the surgical floor or in the wards. The fluid is simply rushed in and acutely rushed in, and patient lands up with the fluid overload. And the risk becomes particularly elevated in the patients with impaired kidney function, and these patients should therefore receive a treatment with a judicious use of intravenous fluid. Also, the patients with congestive heart failure are at increased risk, which can actually cause life-threatening pulmonary edema and congestive heart failure and diastolic systolic heart failure, worsening of that, leading to end organ damage or even death. It is imperative to monitor these patients carefully and to administer minimal required volume to maintain volume homeostasis. Now coming to the most ubiquitous or very commonly used fluid, that is normal saline. It would be very surprising to you for you to understand that normal saline itself is not without its own problems if it is not judiciously used. We have to understand that normal saline is sodium plus chloride and has a higher concentration of chloride ions. Once it is inside the plasma, it is going to dissociate into its components, that is sodium plus, chloride minus. And 154 millimoles per liter is a much higher number than what is found in human plasma or serum, that is 98 to 106 millimoles per liter. With the administration of large volumes of normal saline, hyperchloremia occurs. Without any doubt, it definitely occurs, and possible explanation to the exact mechanism of this pH disturbance is that an increase in chloride concentration adjusts substantial ion difference in plasma, resulting in more free water in the intravascular space. As a result, hydrogen ion concentration in the serum would increase to maintain the electrochemical neutrality. I will explain this in a little detail, as we already discussed that once the chloride has, the concentration of intravascular chloride has increased. As a result of that, the body will try to increase the hydrogen ion concentration inside the plasma to maintain the electrochemical neutrality. Excessive renal and so automatically that will lead to hyperchloremic acidosis. Excessive renal bicarbonate excretion also can occur, which further complicates the metabolic acidosis, and because of that, because of dilution of serum bicarbonate through non-buffered crystalloids, that is normal saline, may contribute to acidosis. In addition, high volumes of normal saline can cause hyperchloremia-induced renal afferent arterial constriction, and which can further decrease the glomerular filtration rate, leading to acute kidney injury. So normal saline is not a panacea and to be used inadvertently. It also has to be used very carefully. Now coming to the buffered solutions, especially acetate buffered crystalloid solution. You must have noticed that generally in anesthesiology, we do not prefer to use acetate or gluconate buffered crystalloid solutions, because studies have shown that even small volumes of acetate containing crystalloid can significantly increase the serum concentration of acetate to 10 to 40 times that of physiological level. And it is proposed that acetate may potentiate hemodynamic instability by decreasing or producing negative ionotropism, decreasing myocardial contractility, as well as causing fall in blood pressure. On the contrary, even lactated buffer system has another problem, because lactate can get converted into, it can act as a hyperglycemic agent. As you must remember that lactate is a part of the glucose metabolism, and lactate is a metabolically active compound that is utilized during gluconeogenesis to produce glucose. Hence, lactate is to be used very, very cautiously, especially in diabetic patients. There are certain contraindications to crystalloids. Patients who are fluid overloaded should not receive crystalloid fluids. Special care is to be exercised, especially when there is a renal impairment. Hypertonic saline is contraindicated in all clinical settings except in the patients with severe hyponatremia or neurologic sequelae. Rapid correction of hyponatremia may cause central pontine myelinolysis, a devastating neurological condition. Hypotonic solutions are contraindicated in patients with or at risk of developing cerebral edema. Crystalloid containing potassium, that is lactated ringer, that is Hartmann's, are relatively contraindicated in hyperkalemic patients, can cause ventricular dysrhythmias. Avoid using crystalloids containing dextrose, that is D5W, D10W, D5, in patients with hyperglycemia, which is obvious. Ringer lactate solution contains calcium ions. Calcium ions can cause coagulation of the blood products in the IV tubing and therefore inhibit the effective delivery. So whenever we are giving ringer lactate, or after completion of ringer lactate, or along with ringer lactate, the blood should not be started. Ideally, blood should be started with a separate IV setup. Certain level of monitoring is required. Patients should undergo the continuous monitoring in terms of signs and symptoms of dehydration or fluid overload, both. Indications that a patient may receive inadequate volume include elevated lactate and creatinine concentrations in the absence of an alternate cause like sepsis. If we have persistently creatinine and lactate raised and there is no specific indication that it might be due to sepsis, it could be because of dehydration. The urine output also requires to be monitored. Ideal urine output is 0.5 or 0.6 ml per kg per hour, which indicates adequate hydration. But it may not be of use in the patients with renal impairment. Now coming to monitor the fluid overload. Patient requires frequent reevaluation, especially the finding of the crackles or the crepitations or the transmitted sounds in the lung fields, either new or worsening of previous crackles, which suggests that the patient is landing in secondary pulmonary edema due to volume overload. And in addition, there may be a new or worsening peripheral edema in the extremities. That also is a potential complication of excessive crystalloid administration. Coming to very quickly, we will discuss a very short discussion about the colloids. Colloids, dextrans are basically the branched polymers of glucose molecule. There is a difference between starch and dextrans. Dextrans are branched polymers, while starches are linear polymers. At one point in time, when I was a student like you, we were not very fortunate to have all these starches and everything. All we had were dextrans or polygelins, and that also only hemaxal. So we used to have dextran 40, dextran 70, or dextran 110. Dextran 40 was called as lomodex or low molecular weight dextran. 70,000 was called as macro, that is a relatively large molecular weight dextran, and 110,000 Daltons was called as Rio macrodex, and that is a very large molecular weight dextran. And another thing was that 40 was around 10%, while 70 was around 6%. They act as their problems with dextrans is, although they may effectively improve the volume, but they act as antithrombotic, decreasing the RBC aggregation. And most importantly, total dose must not be given more than 20 ml per kg in 24 hours. There have been reported where hyperglycemic effect has been seen, and so nowadays they are not very commonly used because we have further better kind of drugs available, and these are the starches or the fluids, the excellent volume expanders. Generally they are the they are derived from the corn. There is also called potato starch by B. Braun company, but generally we do not like to use the potato starch because of whatever our individual experiences. We prefer the corn starch ones, excellent volume expanders. All of the volume remains in the intravascular compartment, and generally this effect lasts for 4 to 6 hours. However, there is a little problem with that also, that they may interfere with the platelet aggregation. Nowadays, the one which is available, that is tetra starch, has the least kind of interference in the platelet aggregation, and they increase the volume by nearly 100 to 150% depending upon the concentration. Nowadays, tetra starch, Fresenius Kabi Voluven or Volulite are there. It's made, as I already mentioned, it is made from corn starch, and it is supposed to be least antigenic, and safely 35 ml to 50 ml per kg can be transfused in first 24 in any 24 hours. Coming to at one point in time very useful, but again nowadays slowly falling in the back burner, that is polygellins. What are polygellins? Polygellins are the degraded gelatin polymers. We have to understand that this gelatin is generated by boiling and extracting the gelatin from the animal bones. So it can expand the plasma of almost 50%, do not have any interference with agglutination, platelet aggregation, but the major problem has been that there have been reported variety of allergic reactions, minor to frank anaphylaxis, especially with Himaxal, lesser with gelofuscin, have been implicated in transmission of Creutzfeldt-Jacobs disease, that is mad cow disease in humans. Slowly they are becoming obsolete. Now, coming to the, as advised by Dr. Nazar sir, this was the basic part of it. I am going to also cover very specific, special situations, what is their requirement and what are the precautions to be taken. And first of all, we'll start with the chronic liver disease or cirrhosis of liver. Now, I will not go into too much of pathophysiology, etiopathogenesis, etc. But we have to understand that in any chronic liver failure patient, there is a large amount of extracellular fluid, which may be stored in the extravascular compartment, as evidenced by the ascites and edema. Unfortunately, these patients may seem fluid overloaded, but they are intravascularly volume depleted and are at the risk of renal failure. You see, we have to again go back to the first few slides where I mentioned that the extracellular fluid has a interstitial and intravascular compartment. So this fluid, although it may be hyperdynamic circulation and all, the fluid has left the intravascular compartment and has actually gone into the interstitium and producing the ascites and edema. Now, over-resuscitation of intravenous fluids sorry, in a fluid overloaded patient in shock may worsen the clinical situation by fueling ascites, hyponatremia, and edema. So excessive fluid therapy may also increase the pH and increase the risk of hemorrhage in the setting of variceal bleeding. So this is the primary problem in terms of the fluid management, that we have to very clearly understand that the intravascular compartment is extremely depleted. But again, here also, crystalloid should be used as a first line of treatment. There is recently some evidence suggested that among crystalloids, balanced salt solutions should be preferred to normal saline, as the risk of hyperchloremic acidosis, I just mentioned that to you, and subsequent adverse kidney events may be decreased, because as you are already aware that most of these patients are about to go and prone to go into the hepatorenal syndrome. The use of colloid solution in resuscitation from shock has been controversial. Whether to use the colloids, our conventional colloids or not, is a major controversy. And the evidence is coming out very clearly that hydroxyethyl starch, one of the frequently administered colloid solutions, rather may not be useful for the patients, or rather may have unacceptable safety profile, notably by inducing potential nephrotoxicity, while offering no benefit other than clinically unimportant volume sparing effect. So this is a very important, I have gone through a lot of literature, and almost 4 to 5 studies have shown that hydroxyethyl starch should not be used as a volume expander or for the intravascular purposes. Some evidence supports that specific use of albumin. Now, if you remember the classification we mentioned, in the colloids, we mentioned the proteinous, and they are, one are polygelyne and another is albumin. Though some evidence supports the specific use of albumin for volume loading in acute on chronic liver failure patients. Indeed, albumin offers numerous advantages over crystalloids beyond the simple volume expansion in the patients with cirrhosis. First of all, it improves the plasma colloid oncotic pressure. So it prevents the egress of the fluid across the intravascular membrane into the fluids, into the interstitium or intracellular compartment, and thus it tries to maintain the intravascular volume too. So albumin is recommended as the first sorry, first line volume therapy for 48 hours, especially in cases of kidney disease improving global outcomes, stage 2, and in combination with the vasoconstrictors in the treatment of hepatorenal syndrome. Finally, albumin is also proven to be superior to the other fluids in prevention of post-paracentesis circulatory dysfunction and related renal vasoconstriction. Now, in a minute or two, I will discuss with you also the adjuvant therapies in the cirrhosis of liver patients. And one of the mainstays of treatment for these patients is the paracentesis or the tapping. There was a beautiful study called ANSWER trial or ANSWER study, showed that weekly IV albumin infusions reduced 18-month mortality in patients with decompensated cirrhosis and persistent ascites despite of diuretic therapy. So that is now the most of the guidelines are saying that albumin can be and should be the drug of choice for the liver patients. Supportive therapy, of course, is the fluid restriction to less than 1000 ml per day from all the various routes. Salt restriction to 2 grams or less per day. Diuretics, combination of aldosterone antagonist to combat the secondary hyperaldosteronism, which is generally produced due to the hepatic dysfunction, and loop diuretic to avoid the hyperkalemia. So spironolactone 80 to 100 milligrams and furosemide 20 to 40 milligrams. We can go up to safely up to 400 and 160 per day if required. If these measures do not help, then the peritoneal tap may have to be used. And to achieve the target weight loss of 1 to 5 kg per day, depending upon the symptomatic fluid retention. If ascites and peripheral edema is present, then we have to be a bit careful we use, because that peripheral edema part cannot be tapped. So we just conservatively try to lose 1 kg per day. If there is only ascites, then safely 5 kg per day of the fluid can be lost. If there is no improvement in spite of high dose diuretic therapy, then it is considered as a refractory ascites, and large volume paracentesis may be implemented. We also have to keep an eye on the PT-INR by monitoring PT-INR and giving vitamin K, fresh frozen plasmas. Rarely we may have to give activated recombinant factor 7, that is NOVO7, to prevent any bleeding diathesis or to prevent any further loss of the blood. Antihepatic encephalopathy treatment may have to be administered, like lactulose and etc. Propranolol is the better choice of beta blocker as compared to rest of them. And any kind of sedatives, hypnotics and NSAIDs are absolutely contraindicated. Avoid high protein diet, hypovolemia, hyponatremia and hypokalemia. I think I have tried to cover, because of specific advice by Professor Nazar sir, I had tried to cover the cirrhosis liver in little detail. So I hope it has been very clear to the students. Treatment guidelines for established acute renal failure. Discontinue. Now we are talking about acute renal failure, not the chronic renal failure. We will come to that in a little while. Mainly, whatever we can do as a anesthesiologist or intensivist is mainly in the presence of acute renal failure. Generally, acute renal failure is because of a specific cause, especially the potentially nephrotoxic drugs. So consider induction of MSAs, administration of activated charcoal. Sorry. Activated charcoal, sodium sulfate to decrease the absorption of ingested toxicant. Obtain baseline data, that is body weight, PCV, total protein, urinalysis, serum biochemistry profile and blood gas analysis prior to initiating the fluid therapy. Identify and correctly any pre or post-renal complications. Initiate intravenous fluid therapy with 0.9, that is normal saline, or half normal saline with 2.5% dextrose. Replace deficits within 6 hours. So you have to understand that half normal saline and half concentration of dextrose or normal saline within 6 hours. Provide maintenance, and then continuing loss of fluid needs to be quantitated in terms of urine output. Assess, correct any acid base and electrolyte abnormalities. Rule out potential treatable causes like renal failure, like hypercalcemia, pyelonephritis or leptospirosis. So provide mild volume expansion and or administer diuretics and vasodilators if patients remain oliguric. We can use mannitol, furosemide and dopamine. Adjust maintenance fluid requirements based on urine output. Recheck baseline data at least daily during the fluid therapy. Change fluid type and supplement with potassium as necessary. So potassium is an optional compound. We have to understand, monitor the potassium levels, and then required give or not give. Consider peritoneal dialysis if no response to above treatment within 3 days. Obtain a kidney biopsy at the time of putting the dialysis catheter in place. If the cause of acute renal failure is vomiting and gastroenteritis, then the specific treatment may be given, and making sure that the caloric requirement of 70 to 100 kilocalories per kg per day by total parenteral nutrition, if required, has to be given. Control hyperphosphatemia and with phosphate restricted diet and enteric phosphate binders if necessary. So I hope I have covered most of the acute renal failure part. Now going to the very quickly the fluid management in chronic renal failure patients. Now chronic renal failure patients are a very peculiar kind of situation there, and they have been in this state for pretty long time, sometimes weeks, sometimes months, sometimes years. So if they come with some comorbidity or coexisting condition to us, then only we have to initiate the acute management of fluid, whatever restriction or fluid maintenance. And daily intake should be less than 1 liter per day. Again, here salt restriction and protein restriction has to be carried out, 2 to 3 gram per day or less. Protein restriction to 0.6 gram per kg per day. And most important thing, as happened, as we discussed in acute renal failure patients, here it makes a lot of difference because of the renal rickets. Phosphorus management, the blood levels of the phosphorus to be kept less than 4.6 per milligram per DL before dialysis, or less than 5.5 milligram per DL when on dialysis. And restriction of the intake of phosphorus should be less than 1000 milligram per day. Now that is 1 gram per day. Oral phosphorus binders like aluminum hydroxide, calcium carbonate, or calcium acetate 3 to 4 times a day may have to be given. Low potassium diet, because chronic renal failure patients have a problem with the potassium excretion. So we may actually have to start the sodium polystyrene sulfonate, the potassium binder. And same thing because of the renal rickets, as I mentioned, because of the parathyroid and other disturbances, the calcium is being continuously lost. So calcium supplementation with vitamin D supplement may also have to be given. Last but not the least is the renal replacement with hemodialysis. Now coming to the very common and most important aspects of our day-to-day anesthesia practice, and generally they are, one is hypovolemia, another is hypervolemia. Hypovolemia, basically when there is a extracellular fluid compartment depletion or depleted, or volume is reduced, and the extrarenal causes are hemorrhagic hypovolemia, gastrointestinal hypovolemia, or excessive skin loss due to whatever reason, high temperature, etc. While in renal causes, we have diabetes insipidus, diabetes mellitus, drugs, excessive use of drugs like diuretics, hypoaldosteronism, salt wasting nephropathies. There can be hypovolemia due to even without any less or loss from the extracellular volume. Rather, the volume may have increased with the low circulatory or intravascular volume. And classical example is congestive cardiac failure, redistribution of fluid, decreased PCOP in cirrhosis, I already mentioned that to you, nephrotic syndrome, capillary leak, that is ischemic bowel third space loss, and acute pancreatitis. Increased venous capacitance due to anaphylaxis, and mixture of all of these in sepsis. How do we diagnose? The serum sodium is a very sorry, a good indicator. If serum sodium is low, then both sodium as well as water has been lost. If it is high, then only water has been lost. Blood urea nitrogen, serum creatinine raised, and BUN creatinine ratio more than 20:1. If that is, if pre-renal azotemia. CVP, two tests will able to tell you whether it is what kind of fluid loss is this. Lower than normal, 8 to 10 centimeters of water, especially in deduct if it is and a patient is on ventilator, then deduct PEEP of if more than 5 centimeters of water. Up to 5 centimeters of water, we need not deduct the number from the total CVP, whatever is available. Volume challenge, 250 to 500 ml of rapid infusion of Ringer lactate or normal saline will increase CVP, but cannot sustain it more than 10 minutes. Then and this is another very important indicator which is coming, or a parameter which is coming, and a lot of literature is coming out. That is a ultrasound guided IVC correlation between the IVC size, respiration, and the CVP. IVC size decreases with respiration. So if we have IVC size less than 1.5, respiratory change, total collapse, then the CVP will be hardly 0 to 5 centimeters. 1.5 to 2.5 centimeters, more than 50, less than 50% collapse, and 6 to 10. 1.5 to 2.5, more than 50% collapse, 11 to 15. Less than 2.5, 50%, more than 50% collapse, CVP will be 16 to 20, and more than 2.5 and no change in the respiratory pattern, or then it will be more than 20 centimeters of water. Coming to the very quickly, hemorrhagic, hypovolemic, or surgical blood loss or fluid loss. Calculate the estimated blood volume, generally in an adult approximately 75 to 80 ml per kg. Categorize the blood loss with help of Fromme-Bézard surgical field grading, and that says 0, no bleeding; 1, slight bleeding, no suctioning of blood required; 2, slight bleeding, occasional suctioning required, surgical field not threatened; 3, slight bleeding, frequent suctioning required, bleeding threatens surgical field for a few seconds after suction is removed; 4 is moderate bleeding, frequent suctioning is required, bleeding threatens surgical field directly after suction is removed; and severe bleeding is a constant suctioning required. Bleeding appears to be faster than removal by suction, and surgical field is severely threatened. So 1 to 2 percentage of EBV is less than 10% loss. You understand? So that is hardly any loss in terms of the estimated blood volume. And the fluid to be transfused is maintenance with normal saline and RL 1 ml per kg per hour. If it is 3 from a Bézard field grading 3, then that means around 10 to 20% of the estimated blood volume has been lost, and we may have to still continue with the crystalloid, but now we may have to increase it to 2 ml per kg per hour. 4 grade is around 20 to 25%, and some amount of colloid, either a starch or a fresh frozen plasma, or any one of them may have to be used. And when it is more than 25%, then immediate starting of the blood transfusion is necessary. Now coming to the management of non-hemorrhagic hypovolemia. Intravenous fluids, irrespective of sodium level, initial fluid is sodium chloride. If if Na is low, then 0.9% normal saline. If hypernatremia, then half normal saline, and strict intake output monitoring, hourly urine record, and depending upon the IV compartment stay, that is 1 liter. Generally, if we give 5% dextrose with water, intravascularly it will be only 75 to 100 ml. In the interstitium, it will reach around 20 to 23%, and remaining will simply enter the intracellular compartment. So that is why we do not prefer 5% dextrose as a fluid of choice for our fluid management. On the contrary, if normal saline is given, then 300 will remain intravascularly, while 700 will reach the interstitium, and 0% will go in the intracellular compartment. Half normal saline, around 170, half of that, generally about half of that. But this one will enter the intracellular compartment, almost 33% of it. And the beauty of colloids, why colloids are preferred, especially in non-hemorrhagic hypovolemia, many times is the whatever we give, 1000 ml we give 1000, 100% remains intravascularly, improving the volume. So according to indication also, non-hemorrhagic hypovolemic shock, in the order of their preference, sodium chloride, lactated ringer, colloids. In case of diarrhea, only crystalloids, lactated ringer or normal saline. Vomiting, isolite G or normal saline. Diabetic ketoacidosis, we'll cover that in a minute. Normal saline. Burns, lactated ringer. Starvation here, because the caloric requirement also may be there, and the intracellular sugar will be depleted. 5% dextrose in water can be given. Maintenance fluid for adults can be any RL, NaCl, even isolite M, while maintenance for pediatric will be isolite P, and required sodium will be calculated as the desired sodium minus actual sodium multiplied by 0.6 multiplied by body weight in kilograms, and we take 0.5 in females instead of 0.6. And what is the protocol for that? It is impossible to measure exactly how much is the total deficit. So empirically, normal saline or ringer lactate at the rate of 30 ml per kg bolus is to be given. RL is preferred if there is a less chance of hyperchloremic metabolic acidosis. But again, as I mentioned, in diabetic patients, we may have to be careful in using lactated ringer. Strict watch on vitals, CVP, urine output, the neurological status, and arterial blood gases. Maintain the CVP around 8 to 12 centimeters, urine output to 6.6 ml per kg, improved sensorium, decreased hematocrit and BUN, creatinine ratio that is less than 20:1, and decreased metabolic acidosis. Coming to last 2-3 conditions now. Syndrome of inappropriate ADH secretion. Syndrome of impaired water excretion with retention of water leading to increase in total body water, hyponatremia, but no clinical edema. So that is the beauty of SIADH. Generally, it is such an acute condition that there is no enough time for the fluid to get retained into the interstitium. Multiple etiopathogenetic genetic factors are there. Stress, surgery, anesthesia, pain, sepsis, inflammatory process, tumor, CNS disorders, etc. So low sodium 130, low osmolality less than 270 milliosmoles per liter, but normovolemia. Increased urine osmolality to more than 100 milliosmoles per liter, and urine sodium also increased to 40 milliequivalents per liter. Normal renal endocrine K levels and acid-base balance. What do? First of all, we try to find out what could be the cause and try to correct the cause. Fluid restriction to less than 800 ml per day, a loop diuretic. If required, if the hyponatremia is persisting, hypertonic saline may have to be given, and high protein diet will increase the renal water excretion. Coming to one of the deadliest and a very important conditions called diabetic ketoacidosis. Generally, it is represented by triad: hyperglycemia, dehydration, hyperketonemia with metabolic acidosis. That is why it is called as diabetic ketoacidosis. Deficit levels in DKA, fluid deficit is 100 ml per kg, then 50% replaced with normal saline for extracellular fluid, 50% replaced with dextrose for intracellular fluid. Sodium 7 to 10 milliequivalents per kg. Potassium may be 3 to 5 milliequivalents per kg or less. Phosphate 5 to 7. Calcium 1 to 2. Magnesium 1 to 2. And severe acidosis with bicarbonates grossly reduced. ABC, depending upon the presentation, depending upon the patient's condition, actually we may have to do the intubation, put the patient on ventilator as a priority, and then start the fluid therapy. Normal saline 10 to 15 ml per kg per hour, up to 50 ml per kg per hour may for first 4 hours may have to be infused. 100 ml in first 30 minutes, followed by next 1000 in 1 hour, followed by next 1000 in 2 hours, and followed by next 1000 in next 2 to 4 hours. So that is generally the protocol which we follow. The blood sugar is more up to 250 milligram per dl, then D5W 100 ml 8 hourly, continue with normal saline and D5W 100 ml for every 12 hourly. Nearly 6 liters of fluid in first 24 hours. Strict watch on CVP, intake output, urine, ABG acidosis, sensorium, sodium levels, and also on serum potassium levels. Role of insulin. Insulin is to be given if potassium is more than 3.3 milliequivalents per liter. After initial sodium chloride infusion has started, initial infusion of 0.15 units per kg regular, that is 10 units per hour, and then add 50 units in 50 ml of normal saline with the following rate: 6 units per hour of infusion initially, reduced to 5 units per hour after the sugar has gone down to 500 milligram per dl, then 4 to if less than 400, 3 less than 300, 2 less than 200. Maintain at the rate of 0.05 to 0.1 unit per kg per hour infusion. Switch over to subcutaneous once sugar is less than 200 and bicarbonate is more than 18. Daily potassium replacement is also necessary. Despite total body potassium, serum potassium may be normal. With volume replacement, the potassium level drops because of the pushing of the fluid in potassium into intracellular compartment. So if the potassium is more than 3.5, then less than 3.5, then we may have to give 40 milliequivalents per liter in 1 liter of normal saline. Between 3.5 to 5, 20 milliequivalents per liter, and if it is more than 5 and if there is no urine, then no potassium is to be given. And that can be confirmed because with help of tall T's in hyperkalemia and flat T's in use in hypokalemia. Fluid therapies potassium supplement guidelines Generally, depending upon the milliequivalents per liter, 3 to 3.5, 28 milliequivalents to be added in 1 liter of fluid, 2.5 to 3, 40, 2 to 2.5, 60, less than 2, 80. And the dose and the rate should not exceed more than 0.5 milliequivalent per kg per hour. Now, controversial thing, bicarbonate. Generally not recommended routinely. Only if pH is less than 7, patient is in shock or coma, cardiovascular respiratory instability, hyperkalemia. If ABG is not available, then we may take 24 minus potassium, patient's potassium found from lab, multiplied by 0.05 and weight in kilograms. But if ABG is available, then bicarbonate can be calculated with help of the negative base excess multiplied by the 1/3 of the body weight in kilogram. So whatever the total amount comes, half correction is done there. Say for example, we have a 60 kilo man and his BE has come up to minus 20. So it will be 1200. 1/3 of that will be 400 and half correction, that is 200 ml. Supportive therapy, of course, oxygen by mask, venti-mask if required, ETT, IPPV, CVP, nasogastric urinary catheter, intake output balance, colloids if MAP is less than 60 millimeters of mercury, systemic less than 90 millimeters of mercury, antibiotics, gastric prophylaxis, and magnesium potassium phosphate correction also may be required. Coming to the last of the special situations, that is burns. Burns is a major catastrophe which can happen to a person, and generally they come to us in a very critically ill state in the ICU. So the goals of the fluid therapy in burns are to maintain the tissue perfusion confirmed by the hourly urine output, to reduce the rate of catabolism or to overcome the negative effects of catabolism. If the burns are less than 20%, then only oral fluids to be given. Exception, of course, if there is a facial, hand or genital burns. If more than 20%, then of course everybody knows the Parkland's formula, especially for first 24 hours. And what is Parkland's formula? Parkland's formula says 4 ml per kg per percentage of burn for adult and 3 ml per kg per percent of burn for the child. And here exclusively ringer lactate is to be given. Total calculation to be transfused in first 24 hours, 50% of the volume given in first 8 hours and remaining 50% in given next 16 hours. In children, 4 ml per kg percentage burn in 0 to 10 kilograms, 40 ml per hour plus 2 ml per hour for next 10 to 20 kilograms, and 60 ml per hour plus 1 ml per kg per hour for more than 20 kilograms. Next 24 hours, no crystalloids, 5% albumin is to be given. Up to 60% of the estimated plasma volume can be safely given. D5 as maintenance for urine, and that is to maintain the urine output of 0.5 to 1 ml per hour. There is a slight modification in the Parkland formula now, and that is initial 24 hours, RL 4 ml per kg per percentage of burn, and in next 24 hours, colloid infusion 5% albumin, 0.3 to 1 ml per kg per percentage of burn. Ladies and gentlemen, I could go on for another half an hour. Unfortunately, I was not able to cover the sepsis part because that would have taken another half an hour or so. But the fluid therapy is a make or break for many patients, especially in evolving imminent or existing crisis. Understanding and executing appropriate fluid therapy is the most essential duty of a clinician. A small oversight or a miscalculation can cause a major disaster for patients. continuous updating of our knowledge is the most essential thing. Thank you, ladies and gentlemen.
Thank you, sir. Thank you very much for the comprehensive presentation. Over to Rajesh, sir.
Yeah, thank you, sir, for the wonderful presentation. That was a very exhaustive presentation. He has covered from the basics of body fluids, from the different types of fluids and the fluid management in different scenarios. And there are a few questions, sir. So I really appreciate we really appreciate your commitment, sir. In spite of you having fever and sick, you are continued with your presentation, and we can see it's a mark of a real teacher, actually.
No, actually, once Binil has given me a task, then I cannot fall, deficient in his eyes.
Okay.
Binil has been one of the very favorite students, and now he is in his own capacity a very big man, and I'm very proud of him to have achieved all these positions, achievements with his own efforts, hard work and sincerity.
Yeah, that's since he has taken off as secretary, he has worked really hard, and that's why we have won the best state awards in the national level. Dr. Binil and Dr. Nasser. So there are a few questions. Are you comfortable to answer these questions now itself, or should we?
That is what I was going to request you, that if they can send me the questions, I shall send them back, because I'm now getting a bit more and more dyspneic. So
okay, sir, yeah.
If you can excuse me for this now.
Yeah, that's no problem.
I have shared I have shared one article which covers entire aspect of sepsis. It is with Binil. It is our own article, so there is no plagiarism or anything. Mine and Madam's article, optimizing oxygen delivery in sepsis. So you can please share it with all of the students for that matter, because it also covers the surviving sepsis campaign as well as fluid management and many other aspects of it. So if you don't mind, may I take your permission, please?
Okay, sir. Thank you so much. Thank you so much.
Binil,
we pray for your recovery, speedy recovery.
Thank you very much.
Thank you, sir. Thank you very much. Hats off you for a long presentation.
No, thank you.
It's around 1 hour and 45 minutes continuously you were talking.
देख बिनिल, तूने मुझे जिम्मेवारी दी थी, तो मैंने वो तो चाहे कुछ करके भी निभानी ही है. I cannot just let it go like that.
And it's just remember my class days, my school, my PG days, hearing the presentation. And thank you, sir. Thank you very much.
Kindly excuse me. I am very sorry.
Okay, sir. Thank you so much. Thank you so much, sir. We will share the article in the PG group. We have a WhatsApp group.
I already shared. I have already shared the article. And
thank you.
Shall we go ahead with our journal presentation?
So I will take your leave now.
Yeah, sir.
Please,
yes,
sir.
Sure.
Thank you. Thank you very much.
Over to Dr. Vijish and Dr. Swati Sudan.
Yeah, Swati, you can share your screen and we can start the journal presentation. So today's journal is also something regarding fluids, so that we can have a small discussion on fluids. And since sir has left anyway, I will take over, and Swati, you can present.
Good evening to all. Sir, കാണുന്നുണ്ടോ sir? Good evening to all. I am.
Yeah, you can continue.
Okay. I am here for presenting the journal titled Perioperative Fluid Therapy for Major Surgery, which is published in Anaesthesiology Journal on May 2019. Authors are Timothy E. Miller and Paul S. Miles. Goal of IV fluid administration is to restore and maintain tissue fluid and electrolyte homeostasis, and to maintain the central euvolemia, to avoid salt and water excess, and to facilitate tissue oxygen delivery. Achieving an optimal IV fluid therapy improves the perioperative outcome as well as is a key component in perioperative guidelines and pathways. From this review, we can get an idea in perioperative IV fluid therapy for major surgery and focusing on the type and volume of fluids, including suitable criteria to guide such therapies. Start with preoperative period. Preoperative fluid management and fasting times main aim is to avoid the patient arriving in the operating room in a hypovolemic or dehydrated state. So they changed the term allowing clear fluids up to 2 hours to encourage clear fluids up to 2 hours before the surgery, which decreases the risk of aspiration, that is gastric volume less than 25 ml and a pH of greater than 2.5. When clear fluids or clear liquids are given 2 to 4 hours before a procedure compared with fasting overnight. It is said that we continually produce saliva along with an endogenous gastric secretions. So after an 8-hour fast, you get approximately 500 to 1250 ml of fluid which is added to our stomach. This acidic fluid is diluted by the drink which we are taken and does not increases the gastric fluid as well as it decreases the acidity of the gastric contents. Enhanced recovery after surgery, ERAS pathways include oral intake of maltodextrin carbohydrate drink 2 hours before the surgery. This maltodextrin carbohydrate drink has a benefit of reducing insulin resistance, improving the patient satisfaction, reduces the thirst, hunger, and postoperative nausea and vomiting. It creates a fit and anabolic state before surgery, which reduces hyperglycemia postoperatively, which is a major risk factor for nosocomial infection. Examples of clear fluids are water, fruit juices without pulp, carbonated beverages, carbohydrate with rich nutritional drinks, clear tea, and black coffee. It is very important to assess the fluid responsiveness because we are expecting an extra fluid loss as well as typically longer fasting times we are giving. So when we have to give an additional IV fluid. Additional IV fluid should be given to the patient with a predicted positive fluid response. That is best evaluated by steep portion of the Frank-Starling curve. That is, small increase in the preload will increases the stroke volume as described in this diagram. And the volume needed for a fluid challenge is 250 ml of a colloid. If it is crystalloid, it is of approximately 100 ml. And fluid responsiveness is defined as 10% or greater increase in the stroke volume. Factors having effects on preload to predict the fluid responsiveness are positive pressure ventilation, lung recruitment maneuvers. These are decreases the preload as well as decreases the stroke volume and the changes in the respiratory cycle. All these all this gives a variation in stroke volume as well as in pulse pressure variations, which can be estimated by the analysis of arterial waveform. They conducted 50 studies with 2,260 patients, evaluating the techniques to assess adult patients with refractory hypotension or signs of organ hypoperfusion, and it is found that half of the patients studied were fluid responsive. And coming to the predictors of fluid responsiveness, central venous pressure of less than 8 mm of mercury, which has a positive likelihood ratio of 2.6 and 95% confidence interval of 1.4 to 4.6. And respiratory variation in vena cava diameter, which is measured by the ultrasound, that is distensibility index greater than 15%. And augmentation of blood pressure or stroke volume after the passive leg raising, which reliably predicted fluid responsiveness, which has a positive likelihood ratio of 11. This is passive leg raising test. Passive leg raising maneuver is done which transfers about 300 ml of venous blood into the right atrium, which mimics a fluid bolus. It should be done along with an advanced monitoring of fluid responsiveness using a pulse contour device or esophageal Doppler to get a better reflection in the reflection and changes of the stroke volume. If any of these techniques are unavailable, the systolic blood pressure changes can be used. And this passive leg raising maneuver can be used during and after surgery to ascertain the intravascular volume status. Come to the intraoperative period. Two literatures providing guidance are studies comparing the restrictive versus liberal fluid regimen, as well as studies comparing goal-directed therapy using advanced hemodynamic monitoring versus control. Come to liberal versus restrictive fluid. Here, the liberal use of IV fluid in the abdominal surgery causes a significant increase in complications compared with the restrictive approach. Patients in the liberal group were given more than 6 liters of fluid on the day of surgery and a post-op weight gain reflecting tissue post-op weight gain of approximately 4 kg, which reflects the tissue edema. And in patients with restrictive group were given only less than 4 liters of fluid on the day of surgery, and they had a maximum weight gain of approximately 1 kilogram. Enhanced recovery after surgery pathways advocates a restrictive approach. The term zero balance strategy indicates this restrictive regimen aiming to avoid postoperative fluid retention as indicated by the weight gain. But the major concern is when you use the excessively restricted fluid approach, it is associated with an increase in the adverse effect like acute kidney injury. Study design is observational study with multi-center restrictive versus liberal fluid therapy for major abdominal surgery. That is relief trial. Compared a restrictive IV fluid regimen versus liberal fluid regimen. Median duration of surgery was 3.3 hours in the both groups, and restrictive regimen with a median of 1.7 liters of fluid administered intraoperatively, and the liberal regimen of 3 liters of fluid. Study result was patients in restrictive fluid group significantly higher risk of acute kidney injury than those with the liberal fluid group. So they adopt a new method of moderately liberal fluid regimen with a positive fluid balance of 1 to 2 liters of fluid at the end of surgery should be recommended. And crystalloid fluid infusion rate of 10 to 12 ml per kg per hour during a major abdominal surgery and 1.5 ml per kg per hour in 24-hour postoperative. Enhanced recovery after surgery guidelines recommend early transition from the IV fluid to the oral fluid therapy after surgery. After major surgery, transition can be done within 24 hours, and this early transition to oral intake preserves the gastrointestinal motility and limits the ongoing fluid loss into the bowel. Come to next, advanced hemodynamic monitoring versus control. Here they suggest a goal-directed fluid or hemodynamic therapy using advanced monitors to optimize stroke volume or to reduce the stroke volume variation. Blood pressure is widely accepted as having significant limitations as a monitor of intravascular volume status because physiological response to the hypovolemia is to maintain pressure at the expense of flow to the vital organs, especially splanchnic flow to maintain perfusion to the vital organs. Algorithm used in the study is first optimized fluid status to maximize the stroke volume, then add a vasopressor or inotrope to maintain a mean blood pressure of more than 65 mm of mercury and a cardiac index of 2.5 liter per minute per meter square. Even a short duration of hypotension intraoperatively, that is MAP of less than 65, associated with myocardial infarction and kidney injury. Come to the study result. There are 3 trials they are conducted: optimized trial, Feroda, and IMPRESS trial. In optimized trial, they found that fewer complications with goal-directed therapy. In Feroda trial, they showed a significant reduction in the complication and length of stay with implementation of the goal-directed hemodynamic strategy. And in IMPRESS trial, Reduction in complication in the intervention group, that they had their fluid status optimized, followed by vasopressor therapy to maintain blood pressure within 10% of the normal. Next is practical considerations. For that, first is the selection, timing, and dose of the IV fluid, and each patient should have a fluid management plan with the local department guidelines. That is, every plan is individualized to the patient. Our aim is to maximize the efficacy as well as to minimize the iatrogenic toxicity. Intraoperative fluid requirements can be considered in two categories, that is maintenance therapy as well as volume therapy. Maintenance therapy to cover insensible losses and urine output. It takes from the beginning of the preoperative fasting. That is basal crystalloid infusion rate of 1 to 1.5 ml per kg per hour, and more is needed for major surgeries associated with large fluid shifts. The next is volume therapy, where the administration of boluses of IV fluid, typically 250 ml, to assist the volume responsiveness. To treat the evidence of hypovolemia with goal of improving intravascular volume and in oxygen delivery. Briefly explain the fluid management in major surgeries. Recommended regimen is moderately liberal approach with a positive fluid balance at the end of surgery of 1 to 2 liters and intraoperative fluid requirement of approximately 3 liters for a 3 to 4 hour procedure. But it depends on blood loss, surgical procedure, and duration. If it is a less extensive surgeries like daycare procedures and laparoscopic cholecystectomy, it requires only less IV fluid, not more than 1 to 2 liters of crystalloid. If the patient is volume optimized, that is not fluid responsive and still remains hypotensive. For hypertensive patient, MAP of more than 65 is taken as hypotension. And if this condition is, if it is a condition, then we have to start a vasopressor infusion without giving fluid. If the volume is optimized, then we should start a vasopressor infusion. Here in this graph, we can see that patient with lower risk and high risk, and the surgery with low risk and high risk. If the patient risk is low and the surgical risk is low, then aim for 1 to 2 liters of positive fluid balance. Here we can goal-directed therapy is not indicated. If the patient risk is high and the surgical risk is low, then aim for 1 to 2 liters of positive balance should be maintained, and goal-directed therapy is recommended. If the patient risk is low and the surgical risk is high, then aim for 1 to 2 liters positive balance, and the goal-directed therapy is recommended. If both the patient risk as well as the surgical risk is high, then aim for 1 to 2 liters of positive balance with goal-directed therapy is recommended, and consider post-op monitoring in surgical ICU. Briefly explain the recommendations for the perioperative fluid therapy in major surgery, which we have already discussed. Just briefing. Minimize the preoperative fasting time, that is encouraging clear fluids until 2 hours before elective procedure, and for predicting the fluid responsiveness, passive leg raising test. Then aim for moderately liberal IV fluid regimen with overall positive fluid balance of 1 to 2 liters at the end of surgery. And for a major abdominal surgery, an average crystalloid infusion of 10 to 12 ml per kg per hour during surgery, and 1.5 ml per kg per hour in 24-hour postoperative period. And ensure that the intravascular volume status is optimized before adding a vasopressor therapy. And the advanced hemodynamic monitoring is needed to measure the fluid responsiveness in high-risk patients. And a goal-directed hemodynamic strategy may perform if the patient's IV status is first optimized, and if needed, we can introduce a vasopressor or inotrope. If it is unclear whether crystalloid or colloid should be primarily used for the perioperative fluid resuscitation, and aim for early transition from IV fluid to oral fluid therapy after surgery, that is usually within 24 hours. Come to the post-operative period. We encourage oral intake post-operatively in all patients. Many enhanced recovery after surgery pathways suggest IV fluid administration to be discontinued post-operatively, even before the patient leaves the post-op and post-anesthesia care unit. It highlights the need to minimize the post-operative continuation of intravascular lines like IV line, arterial line, nasogastric tube, urinary catheter, drain, which further limits the patient's ability to ambulate. If the patient has to continue the IV fluid post-operatively, it is in case of indicated abdominal surgeries, then a restrictive as well as a liberal regimen can be followed. In the restrictive regimen, administered a post-operative IV crystalloid infusion at an average rate of 0.8 ml per kg per hour, calculated with a maximal weight gain of 100 kg or up to 80 ml per hour for at least 24 hours should be given. And in liberal group, it says IV crystalloid infusion of 1.5 ml per kg per hour. The lower urine output and more oliguria during and after surgery increases the doubles the postoperative acute kidney injury in restricted group. Next question is, what IV fluid should be used? Primary maintenance IV fluid for all major surgeries should be an isotonic balanced crystalloid. That is IV fluid which is more close to the plasma electrolyte and acid-base equilibrium. Examples for this balanced salt solutions are Ringer lactate, Hartmann solution, Plasmalite A, and Normosol. 0.9% saline should not be used during major surgery because of the high risk of hyperchloremic metabolic acidosis and acute kidney injury. Maintenance fluid therapy should be achieved with an isotonic balanced crystalline solution at a rate of 1 to 3 ml per kg per hour. Reduction in postoperative complications when using colloids for resuscitation in a closed loop system, and if there is a major hemorrhage, the necessary to quickly restore the blood. There is necessity to quickly restore circulating blood volume, then best accomplished by red cell, plasma, or other blood product transfusion. Coming to conclusion, one of the most common practices and areas of responsibility for anesthesiologists is perioperative IV fluid therapy. Perioperative patients with hypotension or evidence of an inadequate tissue perfusion then should first be fluid optimized before implementation of the vasopressor therapy. Key points for the perioperative IV fluid therapy is preoperatively encourage drinking of clear fluids until 2 hours before the surgery. Intraoperatively, all patients should have a fluid and hemodynamic management plan. Aim for 1 to 2 liters postoperatively in major surgery. Maintenance crystalloid colloid for fluid boluses. Optimize volume first, then add vasopressors as needed, and use goal-directed therapy for moderate to high-risk patients. And postoperatively, early transition from IV to oral fluid therapy and to remove IV lines as soon as possible. Thank you.
Thank you, Swati. This was a good presentation. And since there is paucity of time, I'll just summarize, or rather I'll just give you the learning points that we can get from this journal. See, the learning points are that you should encourage clear fluids up to 2 hours before surgery. So I would ask you why this maltodextrin carbohydrate drink is being preferred over sucrose. Why is the recommendation for that?
As the journal says, hello sir.
Any idea why they have asked for? Why they have suggested maltodextrin carbohydrate drink as you presented it? No.
Yes, sir.
It's preferred over sucrose.
Maltodextrose is a complex sugar with maltose, dextrose, arabinose, and xylose. which has an additional
Correct. It doesn't
additional advantage of,
as quickly as sucrose, right?
yes, sir. It has an additional advantage over the individually it is given, as it is a complex sugar.
The next learning point is you should give the right amount of fluid, right? The right amount of fluid. So it's a tight rope walk. And if you give more fluid, you will get tissue edema, pulmonary edema, and there will be decreased wound healing. But if you give restrictive pattern, you will go for renal failure, hypovolemia, hemodynamic instability. So you should give the right amount of fluid. But unfortunately, we really don't know on which part of the Frank-Sterling curve these patients are, because it depends on it can vary from patient to patient, and it can also vary in the same patient from time to time. So we really don't know on which part. If he's on the steep part of the curve, definitely he'll be fluid responsive. So for fluid, to test fluid responsiveness, what about fluid challenge? What do you, can you just say something about fluid challenge?
Sir, fluid challenge can be given to all the patients where we are expecting a hypovolemia. We can give, if it is a colloid, we can give approximately 250 ml of colloid can be given as a challenge. And if we are selecting a crystalloid, we can give 100 ml of crystalloid can be given as a challenge, and we can see the response. A response can be either seen by invasive methods, volume variation or pulse pressure variation, as well as central venous pressure monitoring.
So you can describe it as TROL for a fluid response. T, which type of fluid you will give? What is the R? R for rate of administration. O, what will you observe? And L, what will you limit? At what time you will limit? So if you can describe it as TROL, troll. So you can say type of fluid. If it's crystalloid, you will give so much. If it's colloid, and then rate of administration you should mention. Then you should see what you will observe, the change in stroke volume or the change in cardiac output, and what will be the limit, right? If the stroke volume variation becomes less than 10%, you will stop giving fluid. So that is how you should tell about fluid responsiveness. And so nowadays we all depend upon the dynamic indices of fluid resuscitation, correct? So now the idea is to give a moderately liberal approach. And again, you have also mentioned that balanced crystalloid solutions are better than 0.9% normal saline. So there is nothing normal about normal saline because it's a hyperosmolar solution. And Sir has already explained in his talk about what are the problems if you give normal saline. So one more small question that I would like to ask you is, can you say something about the ROSE concept of fluid resuscitation? ROSC, that is, you have a resuscitation phase, optimization phase, stabilization phase, and then evacuation phase. So all the postgraduates should go and read about the ROSE concept of fluid management. Okay.
Yes, sir.
And then you have mentioned about so many trials, optimized trial, Fedora trial. So in optimized trial, again, it was not a very, it was not a positive trial. It just said that complications are less, but the mortality, there was no difference. So now we are waiting for the results of optimized 2 trial, which is now going to give you idea whether this goal-directed hemodynamic therapy is going to be of benefit. So the learning points are you should encourage clear fluids, and you should start early starting of oral intake to stimulate intestinal motility. So these are the few learning points that we have got from this journal, and it was presented really well. You have prepared it good. It's a nice presentation.
Thank you, sir.
Over to Binil.
Sir, if you want, you can discuss the chat box questions. Moderators, Dr. Rajesh and you, if you want. And now I will allow to unmute all the participants. If they want to ask any questions, they can also unmute by them, unmute and ask.
Yeah,
maybe some seniors are there. Unfortunately,
I think we can invite comments, and if there are any questions, if something which we know, we can share. Otherwise, we can always get back to you via email or however it's possible.
Yeah, because sir couldn't answer for the sir couldn't wait for the discussions. So if they want to discuss something, they can ask. And Nasser sir is there for concluding remarks. He can say something. And Giri sir is also there. Venkatagiri sir, please.
I think there were only one or two questions, right, Rajesh bhai?
Yeah, only a few questions. I think he has not discussed about the fluid management and renal transplant, and that was probably one question. And Dr. That is from Veena Asthana, and she has shared her number also. Hopefully, we can share the article Professor has shared.
The article we have already shared.
You can share
in the chat box. It is there in the chat box. Everybody can download.
Yeah. And he has not covered about balanced salt solutions also, I think. All the other portions he has covered. Will you share the article in the chat box?
Yeah, it's there in the chat box, and I have already shared in the WhatsApp groups also. It's there in the chat box. They can directly download from the chat box.
That's the optimizing of oxygen delivery.
Yeah. And
yes, difference.
Many seniors also attended today's meeting. Baburaj sir was there. Baburaj sir can unmute and say a few words. Dr. Sanish was there.
Because they have given the volume of colloid required for that. It's like 250 and the crystalloid is 100 ml.
In the article they have
shared like that. I also saw it.
The Finnish trial, they said that it is 250 ml of colloid. 250 ml of colloid that has to be given, and it should be given over 10 minutes. And then there is nowadays the concept of a mini fluid challenge where they give only 100 ml of colloid, and then the change in cardiac output of the stroke volume is measured using the transthoracic echocardiogram, and the aortic VTI is measured, and it should be done 90 seconds after your mini fluid challenge. So they have shown that mini fluid challenges, because when you give 250 ml and test continuously, this fluid remains in the patient's body. So they say that you can try going for a mini fluid challenge. And then you have passive leg raising, where you raise the leg of the bed of the patient from the semi-recommend, as Swati had shown in her picture. When you do that, you're auto-transfusing into the patient 300 ml of blood, which again, because it is the patient's own blood which is being recruited from the lower limb as well as from the splanchnic circulation.
So volume is the same as for colloids and crystalloids?
But in the article that they had mentioned, it was mentioned like that. I really don't know about it.
Yeah. But it's a good article. It's a clinical focus review. It's a good article also.
I think everybody should read that article from Anaesthesiology. It's free for downloading. Definitely you should go through that, and you should know what are the limitations of this dynamic indices, because again, if you have a low heart rate to respiratory rate ratio, if you have an irregular heart rate, if you're mechanically ventilated with low tidal volumes, if you have an increased abdominal pressure, if you have an open thorax, or if the patient is spontaneously breathing, the changes in the arterial trace might not be reliable. In such patients, you'll have to go for the stroke volume variation, the pulse pressure variation. All this will not work. So you'll have to go for passive leg raising or the end expiratory occlusion test. So all this is being described in this, not in detail, but this article will give you an idea about how to go about So if you look at it, if you have hemodynamic stability, there are only three things available to give to the patient. One is fluid, the second one is a vasopressor, and the third one is an inotrope. So you should know which to give at what time. So that is the most important thing. I think we have overshot the time. It's 8:20.
Yes. Anything from or this
Sir, it's not audible.
Vinay,
Sir, it's not audible. You are not audible.
not audible. Now,
Now it's better.
you.
Yeah.
Vinay?
Sir, now it's better. Please go ahead, sir.
Is it audible now?
Yeah, it's audible.
Now
Please
it's
go ahead.
audible?
Yeah. Yes, sir.
No. Okay, okay.
Again.
Hello.
Sir, we can't hear you. We can't hear you. Both Nasser sir and Giri sir not able to hear. I think since they are not audible,
I am
we'll...
audible?
Now it's audible. Please. Yes, sir.
Yes, yes. Go ahead. Giri. No. Giri, you can conclude.
Vinil, you talk.
Okay, sir. So with this, we will conclude today's meeting. Our next meeting will be on next Saturday at 6 p.m. The topic will be physics for anesthesiologists. And Dr. Baburaj from Trivandrum Medical College consented to give the lecture. We all know Baburaj sir does not require any introduction. We all know him very well. He is a great academician. We all are eager to hear him. So please do join for Saturday's lecture at 6 p.m. And thank you for joining us today. Thank you for joining us today, and good night.
When there are more, we can announce this.
Good night.
Okay, thank you.
Nasser sir, Giri sir, please.
Okay.
അതെ സാറേ, അടുത്ത മീറ്റിംഗ് തുടങ്ങുന്ന സമയമായി. ഗിരി സാറും നാസർ സാർ ഇതുപോലെ സംസാരിച്ചാൽ അടുത്ത മീറ്റിംഗ് നടക്കൂല കേട്ടോ. നെറ്റിന് കണക്ഷൻ വേണം.
ഇപ്പൊ കേൾക്കുന്നുണ്ടോ? പിന്നെ
സാറിന്റെ ഇടയ്ക്ക് വിട്ടുപോണ്ട് ഇടയ്ക്ക് കിട്ടുന്നുണ്ട്.
അത് ഞാൻ പിന്നെ ഇയർഫോൺ വെച്ചിട്ട് നോക്കാം. Okay.
And I forgot to mention one name, Mr. Rahul Chaube. He actually is streaming in his Anaesthesia TV our programs. So today also he streamed our PG update in his Anaesthesia TV. Basically, he is from Pune. I think he is from Sancheti, and he is doing very well with his Anaesthesia TV. So now he is streaming our programs, and I think so many people are watching his TV, and we will reach to more people by streaming in this. And thank you, Rahul.
And this will have to be very high standard, otherwise it's very difficult. See, when it's globally.
Actually, I have received so many responses from Pune, Odisha, Bombay, Gujarat, and all for adding in the groups. So it's not only in Kerala. It's all over India. People are watching our programs.
Yes, because there may not be much teaching program in many places. People want that good teaching. That is the thing. Our teaching may not be that much good as we are doing. So that's why I told we have to keep a very high standard and keep that, because people expect a lot from our program, and that is a very high standard. So let's keep it in that high standard every time.
Vinay,
Yes, sir.
is it audible?
ഇത് ഓഡിബിൾ സാർ എവിടെന്നാ സംസാരിക്കുന്നത്? സാറിന് മ്യൂട്ടഡ് ആണല്ലോ ഇത് മോണിറ്ററിൽ കാണുന്നത്. സാറേ പക്ഷെ ഇങ്ങനെ സംസാരിക്കാൻ പറ്റില്ല സാറേ, ആർക്കും കേൾക്കാൻ പറ്റണില്ല, മുറിഞ്ഞു മുറിഞ്ഞു പോവോ. ഇത് ഇടയ്ക്ക് ഓഡിബിൾ ആവുന്ന ഇടയ്ക്ക് പോയിക്കൊണ്ടിരിക്കുക. എന്തെങ്കിലും ചെയ്യാൻ പറ്റുമോ?
ഡോക്ടർ നാസർ ഒന്ന് വീഡിയോ ഓഫ് ആക്കിയിട്ട് ഒന്ന് സംസാരിച്ചു നോക്കൂ.
അല്ല രാജേഷ് സാറേ, പ്രോബ്ലം എന്താ വെച്ച് കഴിഞ്ഞാൽ സാറാണ് ഇപ്പം അടുത്ത മീറ്റിംഗിൽ സംസാരിക്കേണ്ട ആള്. എന്താ സംസാരിക്കേണ്ടതെന്ന് എനിക്കൊന്നും അറിയില്ല, സാറിന് തന്നെ അറിയത്തുള്ളൂ. സാർ ഇല്ലാണ്ടായി കഴിഞ്ഞാൽ മീറ്റിംഗ് നടക്കൂല.
അത് എത്ര മണിക്ക്?
8:30 അല്ലേ നമ്മൾ പറഞ്ഞേക്കുന്നത്? 5 മിനിറ്റ് കൂടെ ഉണ്ട്. സെയിം റൂം, ഈ റൂമിൽ തന്നെ വരും ആൾക്കാരെല്ലാരും.
ബാക്കി GC അല്ലേ
സാറേ?
ഹലോ, ഒന്ന് ചെക്ക് ചെയ്യണം, ടെസ്റ്റ് ഒന്ന് നോക്ക്.
ഇത് ഇടയ്ക്ക് കേൾക്കുന്നുണ്ട് സാറേ, ഇപ്പൊ കേൾക്കുന്നുണ്ട്.
ഇപ്പൊ കേൾക്കുന്നുണ്ട്. അല്ല നമ്മൾ ഇത് മാറ്റി, കണക്ഷൻ മാറ്റി.
ഇത് ബെറ്റർ ആണ്.
അല്ല ഞാൻ വീഡിയോ ഇപ്പോഴോ ഓക്കെ ആണോ?
സൗണ്ട് കേൾക്കുന്നുണ്ടോ? കേൾക്കുന്നുണ്ട്. വീഡിയോ
വരുന്നുണ്ടല്ലോ. ഓക്കെ, ദിസ് ഈസ്
സാറേ, ഇത് കേട്ടാ മതിയല്ലോ.
ഓക്കെ, വിൽ സീ. ഞാൻ പിന്നെ എല്ലാം എന്തായാലും സ്റ്റാർട്ടിങ് കൊണ്ടുവരാം. എന്തായാലും കേൾക്കുന്നുണ്ടല്ലോ അല്ലേ?
കേൾക്കുന്നുണ്ട്. ഇത് വലിയ കുഴപ്പമില്ല. ഇതിപ്പോ വലിയ കുഴപ്പമില്ല. ഇതെല്ലാരും ഓൺ ചെയ്ത് വെച്ചിട്ട് പോയിക്കാണല്ലോ. ക്ലോസ് ചെയ്തിട്ട് ഓൺ ആക്കിയാല്. ഞാനൊരു കാര്യം ചെയ്യട്ടെ, ഞാൻ മീറ്റിംഗ് ഒന്ന് ക്ലോസ് ചെയ്തിട്ട് ഞാൻ വീണ്ടും ഓൺ ആക്കാം. കാരണം ബാക്കിയുള്ളവർക്ക് കയറേണ്ട ആവശ്യമില്ലല്ലോ. ഞാനിപ്പോ തന്നെ മീറ്റിംഗ് എൻഡ് ചെയ്യാം. N for all അടിക്കാം. അത് കഴിഞ്ഞിട്ട് ഞാൻ ഇപ്പൊ തന്നെ റീസ്റ്റാർട്ട് ചെയ്യാം. 1 minute. ഓക്കെ.